Thanks, everybody. This is a great session. I was really hoping we were able to be able to fill this room with employers and primary care physicians being able to have these conversations. But this is a great initial step, especially in this region, Northeast Ohio. Union Hospital is about an hour and 15 minutes south, directly south of where we're at right now. And it is considered a rural community hospital. We have been independent since 1906, 152-bed organization. However, we are currently going through the process of partnering with the Cleveland Clinic right now. At any point in time, actually, an agreement should be inked by next week. Huh?
I look at it as an opportunity to finally attend clinic to work.
We are looking forward to that. And I don't want to spend a lot of time on that, but ultimately, this could have been the sales pitch, and hopefully we didn't fall for that. But ultimately what they said is, if you look at why we, the Cleveland Clinic, have been so successful and have created such a margin, it's because we were specialists and subspecialists, and what we said is just send us your sickest of the sick, we'll take care of them, and we'll do it at a very high margin. That worked out great during fee-for-service days. Now you fast forward into population health and where everybody's looking at value. And that is a model they know simply cannot be sustained. And if you look probably 5 or 6 years ago, Dr. Cosgrove put out a press release that said we are done acquiring entities because, number one, we're doing it wrong, we're doing it for the wrong reasons, and when you look at where we need to go, we are not positioned to survive well in the future. So, they hired Ann Houston as their chief strategy officer to kind of get them going in the right direction based upon where healthcare was going. You now fast forward, and they have brought on a couple institutions. We're their first rural community hospital, and ultimately what they told us, again, couldn't have been sales pitch, they said, you are the second lowest cost provider in the state of Ohio, and your quality is extremely high. We have to learn from you on how to do things in population health. Because our model that has been successful for generations has been, send us your sickest of the sick, and we'll take care of it. And we have an amazing margin that comes out of that. So we're hoping that that's exactly how this is going to go. However, a couple of times we've had interactions during due diligence where they've said, your compliance program doesn't look like ours. No, no, it doesn't. Your IT security doesn't look like ours. Nope. No, it's not. But because we did things like that on a bootstrap budget, that is why we were one of the second lowest cost providers in the state of Ohio. So there is some learning that needs to occur there. But ultimately, thanks for this opportunity to be here. Some of the things we're going to go over here briefly. I'll try not to say some of the same things that have already been shared because the 7 Habits was a great session and actually summarizes a lot of what we've built. And I'll try to see if I can add anything to that. But ultimately what we were going to talk about is collaboration. What does it look like in order to get there? How many employers do we still have left in the audience? Are there any employers that are representing employer interests as a TPA? Got it. So mainly health systems, physicians remain okay. So that was really, when we started to do this, I was in the role of business development and government relations. So I was still in essence on the part of the provider. Even though I was creating a solution for our benefit plan, I was doing so really on behalf of the provider side of our organization, not on the benefit plan side. But we still had to have these conversations. So we will spend some time on what that collaboration looks like. We found that we had to really identify both parties' priorities. We had to make sure we understood what those priorities were to figure out how we could solve each other's problems. My father and my brother are engineers. They taught me very, very early in life, I was the youngest, that if you wanted a relationship that would last forever in the business community, find a way to solve somebody's problem. So that is something that we do a lot of before we ever get to any type of contract, any discussion about contracts. We try to find a way to solve somebody's problem that gives us a whole lot of trust and integrity with that group or that individual. Then we'll show you kind of an example of what we've created at Union Hospital, and then we're going to go over the early results. We have about 18 months worth of data on our direct primary care program, and we'll kind of look at what we've got there. So, you know, what do we need to accomplish first? So many times folks spend time thinking about the idea, and then they very quickly want to jump into that relationship or give their sales pitch or collaboration, whatever the case may be. And there's just simply a ton of things that need to occur between that idea and the actual deal. So, you know, there's many, many steps that need to occur. And these are some of the steps that we took. We needed to kind of research what were the problems that currently existed and how were we going to solve those problems, both on the benefit side, the employer side, and on the provider side, because we had just as many problems on our side. When we talk about the four, no longer the triple aim, but the quadruple aim, as the Vice President of Operations, I oversee all of our employee physician practices. I've got the poster child for somebody that is absolutely angry and unhappy with where the Affordable Care Act has taken things and where healthcare has gone, and the checkbox mentality. And I meet with him one-on-one every other week to try to get him out of that funk, you know, and to find some meaning again in practicing medicine. But that fourth element of the quadruple aim is so important. And so what I mean is we have problems on the provider side too that we have to fix. I had to take a lot of time gaining support from my CEO, our CFO, and ultimately our board. And that took a lot of effort, that took a lot of time. I mentioned it earlier how we did that was ultimately by demonstrating to them that as we move to value, the things that we find margin in now are traded as commodities in the future. And that you have a unit cost for your MRI, for your lab, for your CT, whatever the case may be, you have a unit cost for that. And as transparency tools become more and more commonplace, everybody's going to be trading on that unit cost, bringing that margin down to that unit cost because it's a commodity. So we can no longer hang our hat on the margin that those commodity services produced for us. We have to find margin in another service line, which is intellect, which is relationships. And that's actually what really sold them. That is what pushed the pendulum the other way. You definitely have to gain support from your operational leaders. I have an amazing operational team. None of this would have happened without them. And in the end, they're the ones that need to make this work. So to bring them along early on in the process, you have to have your operational folks at the table and them understanding what you're talking about. If you try to introduce it to them at the end, it's going to fail because they're going to tell you a million reasons why it can't work. Had to also gain the support of our accounting, coding, and billing teams. Ultimately, what we've done with DPC, with capitated payments, with PMPMs, is completely changed how the healthcare service was delivered for the last 30, 40 years. So they got to have a significant comfort level. Gain support of our TPA. When I first went out to our TPA, we have a regional TPA that most of our employers in our county utilize. They were very frank with me. Chris, we see this as competition to us because we have what we consider to be a very strong population health management product that we're offering our employers. And we see this as competition. And kudos to them for actually saying that to my face. Now, we've attempted to continue to work together on that, and they've been, I wouldn't say they've been supportive, but when I've got the employer flanked on my right side, they really don't have any other options, especially when they're self-funded, because there are TPAs out there that say, hey, we'll charge you an administrative fee, we'll do whatever you want with your claims data if you switch to us. So that's coming around, but it was very unique for them to tell the largest provider in the community, your competition to us, as the TPA. That was shocking to me. Gain support of your providers involved. This was huge. I had to take over as Vice President of Operations in a very, very unflattering way. In a matter of 40 minutes, I received a phone call from our CEO saying, Chris, I'd like for you to take on this role. And by the way, I hope you say yes, because I already gave your last job away. And Kim Nathan has my last job. And okay. So when I took over the operations, everybody knows employed physicians. What's the number one thing everybody knows about employed physician groups of hospital systems? They lose what? They lose control. Yep, but ultimately everybody knows they lose money. So we had a huge loss that was there that we had to turn around. They constantly had targets on their backs because of that. So many people said, well, the organization that was founded in 1906 now needs to seek partnership because of the insurmountable losses that are occurring in the employed physician group. So, really horrible things, tons of disengagement amongst our providers. In about, we're 13, 14 months removed from that point in time. We have, and I've got a slide here, we went from 50% engagement to 90% engagement. And there's some key things we've done there. We've become, in essence, a physician-led practice group. I am the Vice President of Operations, so sometimes I do have to make those very difficult decisions. But ultimately, up until that point, from an operational standpoint, our physicians lead that way. And that has been the difference. We have a physician, I'm sorry?
What's the percentage of your employee versus non-employee?
Not all of them, no. So I have a 35 physician multi-specialty group. 15 of those 35 are primary care. The rest round out are general surgery, orthopedics, neurology, dermatology, OBGYN. But we also have a medical staff of about 180 at the hospital. 180, so 35 over. Our operations committee is physician-led. Our EHR optimization and quality committees are physician-led, and our compensation committee is physician-led. We did all that in the last year. Once we've done all of those things, now I was ready and able to go out and start to talk to employers and start talking about collaboration. Because if they would have came in before that, they would have seen nothing but dysfunction. And Chris, can you really put something like this together? Your CEO and your CFO, they sound like they don't want to do this. So we had to go through all of these steps before we were ever able to go out and talk to employers. Once we got our own house in order, then we were able to create focus groups of our employers, our providers, and start to hammer out what those priorities are and what those problems are.
Chris, how long did it take you to get all but the last bullet point accomplished in order to take that next step?
About 3 years.
3 years.
Yep. Yep. It's interesting because I moved into business development probably, I think, in 2012. And I remember my first 2 years, I was so depressed, I literally considered a career change, actually ministry. And this happened where I started to see the opportunity. Because up until that point, everybody beat into my head, well, Chris, the only reason for business development is service line growth. More heads in beds, more butts in beds, more MRIs, more CTs. Up until this point, when we started to realize, and I was able to kind of convey that you're asking me to generate volume around something that's a commodity that is not sustainable, absolutely is not sustainable. That's what changed. All right, so we first had to look at each other's priorities. Primary care physicians wanted to obviously spend more time with their patients. We're able to, as Mike, right? Yeah, Mike pointed out, they changed their appointment slots, under DPC practices to be able to spend more time with their patients. We've also done PFACs, Patient Family Advisory Councils, that actually Kim has helped us set up. That opportunity to get with patients outside of the normal clinic setting and start to think about how to improve things. Primary care physicians want to minimize regulation and the documentation burden. They want better access to data. They want a steady cash flow. And they want to minimize noise and chaos. And by that, I mean literal noise. We took all of the phone systems, all of the calls out of our primary care offices, our clinics, and we built a care coordination center remotely. We utilized our staff to do this. We pulled our staff out of those offices too. And our director of operations, Kevin, after he switched the phones over to our care coordination center and walked into the first practice that we trialed this on, they literally gave him a standing ovation. And I hate the word literally. I yell at my 17-year-old son all the time for using it wrong. They literally gave him a standing ovation because it was so quiet. You know, you would, as a patient, you would walk up to the check-in or registration desk, and you did not receive this, the finger. You would get that all the time. When I used to try to go around on our practices, I wasn't able to talk to our registration folks to see how the day was going, what they needed, because the phone constantly rung. We took that out of the clinic setting. So now you are able to spend more time with your patients. The staff can spend more time with their patients, and there's no noise and chaos. Work-life balance. The physician that I said was so burnt out, this is ultimately what I'm trying to work with him on, is this work-life balance, because he was just done in the fee-for-service race. All right, so now on the employer side, cost, obviously. It's so funny when you talk to employers where they'll say, hey, what are your top priorities for doing something different in your benefit plan? And they immediately, spit out cost. And you know that they pull it back. Well, quality too. I want to make sure that my folks are well taken care of. Everyone does it. But cost, without a doubt, is always the first. Quality is numbers. Access to high-value preventative care. We're going to spend some time on what that is. We define that very, very clearly in what we do. Everybody should know very well. If I say high-value preventative care in our division, they know exactly what we mean by that. They want the opportunity to be involved in creating the care environment that their members are going to go through. So we had to take the time in our focus groups to understand those priorities. So we had to do all of this before we ever talked about a deal or them paying us a per member per month. We had to establish all of this. So as far as our physicians on the primary care side of priorities, we still have a problem. We had a problem then, and we still have this problem today where we have not yet reached critical mass, where we're in a value-based situation where the majority of our lives are value-based. One of the reasons we created all of this was because we're small, we're rural, and nobody was beating down our doors to get into a value-based contract. Medicare was not talking to us directly about an ACO because we didn't have the lives in our community. So we knew if we didn't want to be on the rear end of all the learning and all the good stuff that occurs when you're on the front end, we knew we had to do something a little bit different. And that happened to be with our employers because we had some very forward-thinking folks. However, this today still remains one of our problems because the majority of our lives are still fee-for-service, even though we're CPC Plus Track 2, and that has helped us considerably. We have not yet reached critical mass, so we're constantly almost serving two masters, which is a challenge, but we're learning through it, and we're trying to find that nice way of that high tide floating all boats with all of our operations that we're doing around population health. We're closer, though, due to the larger care teams and the care experts that we've embedded within our primary care practices. And we'll talk about that here in a moment with our high-value preventative care aspects. The participation in the Patient Family Advisory Council, like commented, was an opportunity for physicians to interact with their patients more in a different type of setting. Minimizing the documentation burden. I talked about how we have a physician-led EHR and quality committee. Actually, that started out as a EHR optimization committee. We utilize Allscripts, and there was a ton of hatred around the use of Allscripts. Although if you give me a physician that says they love their EHR, I'll call them a liar because not many enjoy or love their EHR. But we created that committee to get some early wins with our providers on changing some things. We've also been able to minimize that documentation burden by spreading out the demands of population health amongst the entire team. So previously, that physician was asked to do all the health maintenance stuff in that patient interaction. We now have huddles every single morning where we utilize our care coordination tool eye to eye to tell our MAs, to do our rooming folks, to tell our rooming folks, to tell our people checking in what their duties are for each patient that's on the schedule. So that way that physician does not need to spend time getting those important metrics up and checked off. That is somebody else's job. That's also done during our pre-chart checklist process. Mike talked about that earlier too. We have that in place. So a lot of those things are caught 1 or 2 days before, and then what isn't caught is caught during the huddle, but none of that is done or caught by the physician. So that's how we're minimizing documentation burdens. Better access to data. I talked about eye to eye, letter I, number 2, letter I. That is our care coordination tool that we utilize. Every 5 minutes, Allscripts is purging data into eye to eye. So it's very, very much current. And that is where we do all of our reporting. Allscripts is not rich on the reporting side. That is also what produces our huddle reports every day and our gap and care reports that we utilize in those huddles. But the thing that's missing, and we've said this for years, is primary care physicians were being asked to fight Mike Tyson with one arm tied behind their back because the only data they have is what data is in their EHR. And that's a major limitation. So when you work with self-funded employers, and that's how we utilize Employer Advantage. They've helped us a ton during this process, setting up the entire model, but then ultimately understanding the data. So when we work with a self-funded employer, we ask for a 3-year historical data dump of their claims. We put it into JED system. JED system scrubs it in a way that produces a patient synopsis report for us, which our navigators, all of our care team members utilize. That report's updated every single month. And so when the patient's coming in, our caregivers are able to pull off that report, and it shows them where they've been for everything. The only thing that may not show up there is if they had a flu shot done at their workplace because no claim was generated. So in that handy report, everything's broken up into windows. All their E&M codes are in one section. All of their meds, doesn't matter who they're prescribed by, is in another window. Their ER visits is in one window. Inpatient stays, another window. All their diagnostic codes that have hit the claims system is in another window. So it's fantastic from the standpoint of, Kim, I seen you've been to the ER 6 times in the last 8 months. What's going on? Let's talk about that. It changes the conversation drastically. You're able to then utilize what we've been trained in, like motivational interviewing, as opposed to just giving up because you have no idea where your patient's been. It also changes the situation from maybe individuals that aren't that savvy of healthcare consumers. And what I mean by that is, hey, did you have an MRI done, on your name your ailment? No, I haven't. Well, yeah, I see that it was done here. There's a claim here, and it was done at so-and-so hospital. So before you even came in, we went ahead and grabbed that impression, and we know exactly what's going on there. That helps a ton, as opposed to if you would have had somebody that's really energetic on your clinical team that did a great history, and all of a sudden they learned, yeah, I had an MRI done somewhere up north. If that person is still energetic and they haven't been beaten down by all the processes, they may start to call 15 institutions to see if they can find it. That doesn't happen. But now, there's no question about it. We know exactly where that was at because it's in the claims data. Steady cash flow, that's one of the things that we need. So fee for service, as many people know, there's declining reimbursement there. The state of Ohio is looking at cutting Medicaid right now 5%. That'd be on the hospital side, not on the practice side. But You see declining fee-for-service reimbursement everywhere. As many people here know, accounts receivable is a nightmare when it comes to trying to collect money on what the services are that you provide. And working with employers can create guaranteed, timely funds through those per member per month fees, as many folks have found. And like we talked about, minimizing the noise, another one of our primary care priorities, and I talked about how our care coordination center has done just that. Everything is centralized through there, from prior auths, prescription refills, just embedded RN triaging in there now. So we have 2 RNs in there. They work with all 15 of our primary care providers on protocols that everybody can agree on. Can you believe it? Triage protocols in our care coordination center. That is how we minimize the noise in the office. That is how we're able to give folks their time back by all of this stuff occurring through people in top of license, through individuals through their top of license. Allow folks to work at the top of what they've been trained to do. And that's working out great. Before this, our care coordination center was still in place, but we didn't have RNs doing triage there. Those physicians were getting instant messages all the time. What do you want to do for Beth? What do you want to do for Betsy? Here's the symptoms. Now our RNs can work off of our protocols and be much more agile. And that better work-life balance. So many studies are done out there. Between 40 to 60% of physicians experiencing that burnout. Employee physicians are among the highest, specifically for individuals that were independent and then went into employment because that potential loss of autonomy and things like that. However, we're attempting to minimize that ourselves by being physician-led. So we, also in this work-life balance, especially for individuals coming out of independent practice, we've tried to look at other tools and tactics to be able to minimize that. And some of those tactics are around peer interviewing. So back in the day when they were independent, if they needed an MA, they interviewed them. They made sure it was a good fit. Well, a lot of times in employment settings, you've got some administrator or manager somewhere hiring them, and that physician the first time they see him is on the first day that MA comes to work. We do peer interviewing, our MA shadow with the other clinical staff. The physicians interview them so they know exactly who they're getting. We work in what we call pods. We have 4 primary care pods that we were able to share services better. We have anywhere between 4 and 8 physicians in any one pod. But we allow that pod to come up with their own schedule. So the providers decide what their schedule is going to be. We have some guardrails there. We do need to consider expanded access. So what that means is some evening hours, some Saturday hours, but however you get to that is totally up to you. But that's gone a long ways as well in some of that work-life balance. We've got younger physicians that want to come in early so they can get done at 4. We make it happen. If we've got people that are not morning people, they work till 7 p.m. and it suits them just fine. When I talk about our physician-led EHR committee and our operations committees. So,
Do you have a cap or a priority of panel size expectation?
we are just going through that right now in our operations committee. What was that?
Do you know where it's headed? Like, do you have a number or?
So, when you look at, I think AAFP did produce sums like 1,800 under population health. I've got some providers with like 4,000 to 4,500 panel size. Yeah.
In Norway, it's 1,450 is what they have found to be kind of ideal per physician. That's with a team-based care. It's also with having a nurse practitioner who does some of that. About a third of an FTE of nurse practitioner. So it's actually quite less than someone themselves.
Yeah. Yep. Great question. So that is actually coming up in our operations committee as something we need to hammer out over the next couple of months. It's like I said, I've got one physician that just will not give up 4,000 lives. Yeah. So understanding on the employer side, the whole cost situation here. When you look at this Kaiser study that they do every single year, From 1999 to 2016, 303% increase in the employer contribution of healthcare premiums. Now, when we look at this is the workers' portion of those premiums. So what you have here on the bottom, I know it's probably hard to see, so I'll read it here. On the bottom is overall inflation as a factor from 99 to 2016. You've got how workers' earnings have gone during that same 17-year period. But then when you look up here, this is where health insurance premiums have gone, and this is where the workers' contributions to those premiums have gone. Or as Jed likes to say, we give you a raise
In September, and then take it away in November.
Yep.
We increase your payroll deduction.
And I feel that as an employee, and I'm sure probably some of you feel that. It happens every single year. So this is also not sustainable. This isn't sustainable for our employers. This isn't sustainable for our workers. So that is how you understand what their priorities are and find ways to try to solve those problems. Satisfaction. Our employers obviously want their members to be satisfied with the benefit plan and the options in the benefit plan that they've chosen. That's one of the mainstays of retention for talent. They want to know on the quality side, are we impacting these key areas of health? Right there. Kim Nathan, our Director of Business Development, oversees our community health needs assessment. And guess what our top areas are in our community health needs assessment? Nope. Chronic disease, from a chronic disease standpoint. Obesity, diabetes, hypertension. Guess what shows up on our prioritization matrix for all of our key metrics? Obesity, diabetes, hypertension. Isn't it amazing how things actually kind of work out? The employer simply wants to have a very deliberate conversation on what you're doing to impact these metrics and how can they help. That's what we have found. They want to have those conversations. So we're going to spend a little bit of time now talking about high-value preventative care. This is a slide here that shows just simply how deductibles have risen. Not necessarily high deductibles, just deductibles. How deductibles have risen over time. And why it's so important for us to have high-value preventative care. So what we've learned is as deductibles have risen, we start to see two behaviors. I'm demonstrating one behavior here now, but we actually see two behaviors. And if we all remember, health savings accounts were enacted in 2003. So now we start to have about 13 years worth of good data on health savings accounts that are coupled with a high deductible health plan. But what we're seeing in the data is about 33% of folks say they avoid care and prescriptions because of that high cost on the deductible. But then what happens is the moment you have a larger family or somebody that has chronic conditions, and once they meet that deductible, we see the exact opposite happen. We see overuse behaviors. So deductibles have done both sides. Now, I'm not here saying high deductible plans are bad. That is not what I'm saying at all. However, when they are coupled with high-value preventative care in a team of primary care like this, that's nirvana. So a couple more studies. Rand Corporation, Kaiser, JAMA's Internal Medicine article all found that there truly is a reduction in cost. First year, second year, when an employer moves to a high deductible plan, without a doubt, there is a reduction in cost. That reduction, though, is unbiased. And what they found in those articles and key economic studies is that because it's unbiased, yeah, you see low-value cost being reduced, but you see high-value stuff being reduced as well. Your preventative visits, your labs for your chronic conditions, your medications for your chronic conditions, and all those follow-up visits are being reduced. This is evidence in research. I apologize. I sent this slide deck and then I updated. There is, I have it. There was another study that was just done, just released by, I'm trying to remember who was one of the very influential economic institutes that studied, and they followed an employer that moved 75,000 of its employees, covered lives, 75,000 of their covered lives from a 0 deductible to a $34.50 deductible, and seeded the HSA with $34.50. And what they saw were significant reductions in people going for high-value care. Your vaccinations, your preventative visits, your chronic meds, and I do have that study, so I apologize that I didn't get the updated slides to the folks here. But that was a very impressive study. And that mimics another study that I had found years ago, was those behaviors actually became worse for employers that seeded money in the HSA, because folks see that money as now their money, and I've got to hold on to that. And which is, I mean, you want to talk about counter to what you were trying to do. Hey, if I give them this money, they'll use it to go and do this care that's suggested and recommended. So that was a fascinating study. So the lesson is, high deductibles are not bad. High deductibles without high value preventative care worked into it can be bad. They want that opportunity involvement we talked about. They want to sit at that table, and ultimately we say, why not? Because they are one of our biggest clients, self-funded employers. In my region, even our small employers are still self-funded because they want to do what they feel is right for their lives. And that is not live by somebody else's rules, but be able to live by their own rules. So even our small employers are self-funded in my community. And ultimately, they want to receive accountability reports. So we speak quarterly with our employers around key metrics that they find important to themselves. So briefly, what I'll do is I'll talk about what we've created here. Ultimately, healthcare in a fee-for-service world rests on the head of a pin, on an inverted pyramid here, where all of your high-margin services are at the bottom here with your lowest volume of individuals. And then your little to no margin services are what we've been trying to push for, these past 5, 6, 7, 8 years in population health and primary care, behavioral health, home health. And so ultimately, what we're attempting to do is work with employers to put the margin back in the top of that pyramid where you interact with people all day long, every day. Whereas down here, it was hoping and praying that somebody was going to come in for surgery so we could have that margin to keep the lights on. So that's what we've been able to do, is work with employers to put the margin back at the top. We've created a capitated package of high-value preventative care services. Those include primary care and acute care services, all of your E&M codes. And this is very simple. Our contract is extremely simple. We take all of the CPT codes that would happen in the four walls of a primary care office and we slap them in the contract. We take probably, I think it's 65 to 70 of the most commonly used labs. And guess how we found that out? We talked to our physicians. Hey, if money was no issue, what labs do you order the majority of the time that cover 80 to 90% of your needs? Those were the labs we put into the contract. We then worked with our own laboratory at the hospital to say, I want cost. So give me cost and I'll reimburse you. Once I get the employer's PMPM, I'll pay your cost on those labs as they come in. Health coaches, they're embedded in our primary care practices. We have registered nurse navigators that are trained in motivational interviewing and health coaching. They're embedded in each of our pods. Behavioral health, we have licensed independent social workers, not psychologists at this point in time, because in our community they're very hard to recruit. Even LISWs are hard to recruit. We're getting ready to hire our second LISW now. The first one traveled until the physicians were comfortable using an LISW. Now the need was there, and she actually more than paid for herself based upon the code she's allowed to use. But for our employers, she's covered 100% under the PMPM. But for the other lives that utilize her, she bills. So now we're hiring the second LISW with Beck. Nutritional counseling, all of our employers that contract with us, they have 100% access to our nutritional counseling covered under the per member per month fee. Medication therapy management done by a medication therapy management trained pharmacist that does not only med rec, but primarily the ability of working as a provider, working with the patients to say, okay, you're not therapeutic, so let's see what we can do to get you therapeutic. Many studies have demonstrated that around 30% of prescriptions written are in conflict with what that patient actually has written as an entirety on them. And our pharmacists are able to catch that when we have access to all of the claims data. Prescribed exercise, we do warm handoffs. So we have agreements with all of the gyms in our area. And when we've got somebody that is struggling in that regard, we do a warm handoff with that gym. The nurse navigator meets them there, introduces them, works with them as long as they need to feel comfortable. Those nurse navigators also go to the grocery store with our diabetic lives to help them learn how to shop, how to read. You can do it in their office, but it's not the same as doing it in the aisle of the grocery store. Lateral, like I talked about, is included in those capitated list of services. So ultimately, what does it kind of look like? You take your primary care, you take your behavioral health, your nutritional counseling, your MTM, your lab work, and an employer pays us a per member per month fee. It's that simple. I'm glad you told us the 9 to 12% because I told Kim, we got to go back and make sure we're rated right in there.
We'll send you the calculator.
That's right. That's right.
And when you said, this is how you move the value, right?
Yeah, right.
And so when you said to an employer, we put this bundle together that we think is going to, put the value back in this kind of care as this other becomes a commodity, and it's oftentimes not the right thing to do anyway. Well, what's the normal response when you first say it? Is that a curiosity?
The normal response is that makes sense. It actually is. It makes sense. They sometimes then, it makes sense in theory, but then when they see that I'm increasing one of their categories of care, which is primary care, some struggle with the leap of faith that that is going to result in downstream savings. So they
the total cost.
Yeah, correct. Mm-hmm. They realize that it makes sense. I need to try to encourage my folks to have a good, strong relationship with their primary care physician. I agree that I could probably pay for that, in advance. That makes sense. But for me to maybe in some cases double what their quarterly or yearly annual review says on primary care, they sometimes do struggle with that.
Is that because they don't see the other going away?
That's their concern, especially when it is a hospital. I did have one employer that said, wow, if I do this with you, you'd ultimately be monopolizing everything. I said, we're the only healthcare system in the area. We monopolize it anyways. But what we're here trying to tell you, we're trying to keep you from getting into the hospital. And in the essence, you're going to hold us accountable to that. In the end, if we're not doing it, you get out of this contract.
Well, and bad publicity too.
Exactly. Nobody else is going to use it.
Hospital scandal.
Yeah,
Yeah,
absolutely.
no, and that's how we present this is, because we got folks who say, well, what's the withhold on this? Where's the risk sharing? Where's the bonus payment and all this other stuff? I said, well, our suggestion, our business model, if you will, the only thing we ask the physician to put at risk is your reputation. How important is that to you? Once you have that kind of conversation with an employer, they begin to realize, well, damn, that's what's on the line for us every day. We have a manufacturing malfunction or something like that, we're going to have all sorts of bad press. And so that's that. And real quick, Mike, Chris, I want you to talk about the first bucket in the presence of a high deductible HSA plan.
Oh, yeah, sure.
But Mike, you want to...
I got a pin on it, so I remember it.
I was going to say that, the other thing is primary care practices take on the risk of being, you take on a population that has unlimited access to primary care. I mean, we see that as a floodgate. If we can just pouring in. And they can. You can have really busy days and you really work hard so everybody needs to be seen that day. So there's a work side of risk that's very real for the primary care practice to take these things on. I just remember the conversation I had with an insurance company, not to be named, but we were working through our first contract, our DPC contract with the people they wanted to assign to us, and there was 6 actuarial people around the table that were absolutely convinced that if they doubled our payment to us for the in the PMPM version, that they would not regain that at all. And to have that happen, they wouldn't say that they
Model doesn't allow for that.
yeah,
That's
there
right.
was no consultant anywhere that would tell that it was going to work. And it took a lot of arm twisting to make that leap. And there was a leap of faith with the
Yeah.
insurance plan,
Yeah.
and they saw us as an experiment.
Yep.
And then when it worked, they didn't even want to give us the data after the first year because they wanted to keep paying us that lower rate. We had to raise the PMPM.
Yeah.
And it was pretty shocking because I knew the head actuarial person personally, and he
Yeah.
was embarrassed by his company's behavior around that.
Yeah, that's exactly right. So Jed wanted me to talk about, so you will run into a stumbling block, and your really, really savvy brokers will bring this up as a stumbling block, is that if you're working with an employer that has a high deductible plan with a qualified health savings account, you have certain ERISA exemptions you need to be concerned about. So what that means is if an employer offers a high deductible plan with a qualified HSA, the government wants that HSA to be utilized, that tax-free money to be utilized before that individual, that member, that patient, to enjoy any other benefit. So the government says, I'm going to allow you to have this tax-free money in this health savings account, but you're not allowed to enjoy any other benefit until you have reached your deductible and satisfied that deductible. So ultimately, this violates that because that employer is paying for this in advance, and it is an additional benefit that sits on top of their current benefit. So what we did ultimately is we utilized the exact wording that's in the IRS rules that states there can be disregarded coverage that is a safe harbor and separate from what I just said. And what those services are is anything prevention, anything wellness related, and anything chronic disease management related. So what we did is in our summary plan description, and with the employers we work with, we build our entire contract around that definition. It's everywhere in the contract, and our summary plan description mimics that. Those 3 areas, everything is wellness, prevention, or disease management. Now, if you see a patient for something that falls outside of that, we consider it acute. And if that member is a high deductible member, they have to pay for it. There's no way around it. Now, if it's an 80-20 or something without a health savings account, all bets are off. It doesn't matter. You can provide all the benefit you want to them. But if it is somebody with a health savings account, a qualified health savings account, you do have to make sure you have that language in there and train. I thought this was going to be a stumbling block with our providers. They learned it very quick. It was not a problem.
You could split your acute care out separately and pay that out of the HSA.
Exactly. Yep. And that's what.
The employer could make the contribution to the HSA.
Yes.
Pay.
Absolutely.
Is that verbiage available in any of your debt contract posted online or something?
I do not, but we can definitely, work with somebody to get it out. Yeah. Mhm. Yeah. So does that make sense of how to kind of work within the IRS rules to make sure that happens?
Yeah, so the behavioral health work they're doing, the nutritional counseling work they're doing, and medication therapy management work they're doing is part of that much larger chronic condition management piece.
Yep.
The disease management and at times care management, care coordination. So, or preventive or wellness. But these guys don't get hung up on which bucket it comes out of because the way the document is written, it leaves the burden of audit in case an employer's HSA plan gets audited and allows them maximum flexibility.
So for our DPC lives that come in, our physicians think through the process of, okay, what they're in for today, can I in any way tie that to wellness prevention or chronic disease? The example we love to use is I get sinus infections all the time because of my allergies, deviated septum, things like that. That's not acute because of my allergies. My complications from my allergies are sinus infections. So if I go in for a sinus infection, which I know I'm not supposed to, but I'm a baby when I'm sick, it would be covered. Now, if I'm out mowing and I twist my ankle, you can't describe that. You can't explain that away as a chronic disease, other than stupidity. And I think that's
You're
covered.
trying to do it fast.
Yeah, that's right.
To avoid
It was wellness. It was a wellness
and then
event.
you trip and
Yeah,
fall.
right. Very good. I didn't think of that one.
Cut grass.
That's a major spirit of life.
Then ultimately, any other service that falls outside of what you see up there goes through the normal benefit plan, fee for service.
And we explain this to the employer because it helps cannibalize downstream spending in more expensive venues. If you allow this sort of extraordinary fee-for-service opportunity to exist, there's less of a chance of specialty care done.
Real quick, I'm just going to take you through our early results. My staff is extremely happy and engaged. 52. We were in the 52nd percentile, 90th percentile in our last employee engagement survey. Primary care financials. Our primary care financials improved by 54% over last year. That is a $705,000 turnaround. This happened because of DPC, but because we built up our population health muscle, we were also prepared for CPC Plus Track 2, which has been a significant boon to us as well, and encourages all the other efforts we've done. And that, in fact, it's paid for all the efforts we've done because we already built the Care Coordination Center, we already put the navigators in there, we already put LISWs in there. CPC Plus Track 2 helped us pay for that. But $705,000 turnaround on 15 providers. So this isn't, 100 providers in my primary care offices. This is only 15.
Is that net after your
Yep.
centralization costs?
After the what?
After the centralization? and
Yes.
all that?
Yeah. All admitted. My salary's in there. My care coordination center salaries are in there. Leases are in there. All of that. So that's $705,000 net. Yep. So real quick, then on the 15 months of employer data, our DPC lives cost 13.1% less on a PMPM to care for than non-DPC lives. 13.1% less. Now, this is what's killer. That 13.1% includes the $330,000 my benefit plan pays my physicians to do this care. That includes a 73% increase in utilization for facility spend because we're getting people in up on their gap in care reports. We're getting them in for their mammography, we're getting them in for their colonoscopies, we're getting them in for all of the high-value preventative care services they need to have. That shows up in our facility spend in our claims data. So that's a 13.1% decrease, savings, while also increasing utilization for those services by 73%. That also includes a 12% increase in prescriptions utilization because, what's that?
People are taking their meds.
Yeah, exactly. Our navigators tell anecdotal stories constantly that these DPC lives came in on high deductible plans that hadn't been seen in years. Their hemoglobin A1Cs out of the stratosphere, or they had no idea they were diabetic, hypertension. You know what I'm saying.
And so what I love, forgive me, is the CFO of Chris's Hospital and I think it was our second meeting ever, went up to the whiteboard and started to noodle with numbers. Just started pretending like we knew what we were doing, and it helped. I love it. It actually worked.
Yeah. Real quick, early results, inpatient spend, DPC. You can see how much less it is on the inpatient spend side. We're getting things earlier. Utilization on the inpatient side is less.
And what's the percentage of your DPC enrollments to your plan?
About 33% DPC 66.9. So we still have not hit that critical mass yet. But this coming year, we're rolling out additional incentives.
And your providers are not, they can be rolled, they're not exclusive to
That's correct. Yep, that is correct.
Product.
Right.
They do
Yep.
have the product.
Something else to consider in that $330,000 is also a 20% benefit reduction for folks that are highly engaged inside the DPC program. If we have a structure that we go through that says somebody's kind of engaged, and that's 10%. Somebody that's really engaged is a 20% premium discount. That's included in these numbers as well.
I was just thinking,
Yeah.
Holly, your point's an interesting one, if I heard it correctly, because, there's a big debate about what's more work, being with a foot in both canoes, fee for service and comprehensive payment, or, you have to make the shift and all that sort of thing. And I think what we're learning, not only from this, but from places like Clint Flanagan's practice Nextera out in Colorado, is that with the right tools, especially since it's more physician-led, docs can balance both in ways that did seem a little less difficult than it seemed before. But I think it's still difficult. I mean,
Well, and I'm sorry, because tomorrow I'll talk about this, but we have the DPC plan, which is really the Jim has some folks on, that is really a value-based capitated primary care covered service model. Sort of a payment model, not a practice model. And then we have these guys, that is the higher end kind of concierge/DPC. And I'm looking for that middle, but I consider the middle range of something like this that I could take. Do I have to take all 300-400 primary care providers and make hands and put into it? Do I have to, we've talked about creating a high performance primary care network, which I value my body and my height and don't want to get shot to pieces in that. So I'm struggling, but this could be a nice evolution to kind of hit the middle ground for employers that don't want what I consider more high-end, they're more, I'll say, fluff in services versus the real value, which is the taking all the premium profit, not having a lot of the true DPC model. So.
and overall, I think that the percentage, in terms of from a practice's point of view, I've heard this twice now over the last month from different sources, that if you are 63%, like when you move from 33 to 63, you're, that's this
That's the
magic number. Then as a practice, you'll have enough room economically to get off the hamster wheel and be able to provide more services to your total panel. And who knows if that's exactly correct, but it seems to be,
And so when you're
close.
contemplating panel size, let's say you're contemplating panel size for providers that are doing both DPC and non, so it's these providers.
Correct. Yep. So something also I didn't mention earlier. So through our care coordination center, and we have a really nice state-of-the-art phone system that we utilize. I can track everything. Every call receives its own disposition, so we know exactly what's going on at any point in time. But we're also able to give our employers their own phone lines. So when that calls into the care coordination center, hello, this is Allied's, Allied's health plan, so they almost feel that concierge type, but it's very simple. It's a phone line. So that's something neat. What I should point out, though, in full transparency, it's not all sunshine and lollipops. We do have work that still needs to be done. So some of our next steps are ED spend. As you can see, DPC actually tracks slightly higher than non-DPC folks. So what we do with that, we work with Jed's group. They download a list of individuals that utilized ED visits that are DPC, and our navigators start calling them and interacting with them. Okay, was this a fluke? Was this at 2 a.m.? Something that we could not control? Or are you going 6 times a year, 3 times a year for something else? Is it asthma? Okay, well let's figure out something else. So you call my cell phone directly. You're not going into the ER, that kind of stuff. So not all sunshine and lollipops. We still have some work to do in some of those areas. However, the nice thing is, of those folks that went into the ER, 0 of them were admitted. So that was cool. So some next steps that we have is, you heard me talk about musculoskeletal ultrasound. That's something we're really, really excited about. Without a doubt, for a self-funded employer, that is going to decrease their spend tremendously. It's kind of, and I probably latched onto it for a specific reason. One of my backgrounds is ultrasound. My other background is sports medicine. So that makes a lot of sense why I'm so interested in it. But I just haven't been able to get traction until this point. And now I've got providers talking about it because of that Achilles rupture that we found the other day. So no MRI for that. The time to surgery was cut tremendously. Imagine how the patient felt, knowing that I don't have to now go to an MRI and all that. So.
What about virtual health solutions?
Good. So that was going to be one of my next steps also, is I heard some people talk earlier about employers that have multiple locations or locations across geographic divides. That is a must-have. We don't have that yet, so that is one of our next steps. We're a small community, so luckily some of the employers we work with, 80-90% of their lives are in that community. Sales force is outside, but we have some very, very successful companies in our community, so they're starting to buy others. We know that is something we have to do, so telehealth, without a doubt, is something we have to have in order to offer a true, robust solution to our employers.
Let me just jump in and say we've got about 20 minutes, and just wanted to perhaps